Jud Knox is the CEO of York Hospital and is going to give you the perspective from the hospital world.
I am. Thank you. I noticed that there were no administrators from New Hampshire hospitals that came here tonight. I don't know what that means, so I'm the guy from the other side of the border. After the introduction, I thought I was catching on. But
we only invite the best.
Thanks, Chris. I've been involved in healthcare delivery for about 36 years. The opinions that I'm expressing tonight are mine, and I'm sure every other hospital administrator you might ever run into would disavow my perspective. I believe the current system of healthcare delivery is unsustainable, and I happen to be someone who believes that there ought to be some sort of march toward universal coverage. Having said all that, what Wendy talked about in terms of the issues of uninsured, in terms of what I would call price shifting, are very accurate. If you will, the haves pay for the have-nots. That's really how the system works. In fact, those who have better coverage pay for those who have less better coverage. So those of you with commercial insurance are help paying for those on Medicare. And that's how the system, actually without the current, given this current system, without price shifting, the system would collapse. As a not-for-profit place, we're trying to make things work from one payer to another payer to get ourselves to a break-even point. So price shifting absolutely occurs both because of uninsured folks and the underinsured. There are access issues that are caused by uninsured. Obviously, people uninsured feel disenfranchised, feel like second-class citizens using the system, and even those who feel free to use the system often feel that they're not being treated on an equal basis as others. I certainly handle complaints. People say, I know they didn't treat me as well because they know you, provider, know that I don't have insurance, which our doctors don't know at the time they're treating me. I think the hardest part about the uninsured issue is none of us really like it. None of us feel good about it. None of us, those of us who are insured, I don't think feel real good about the fact that there's a whole bunch of people that aren't insured and are treated potentially different than the rest of us. And certainly those who aren't insured don't feel good about the barriers that they encounter. And fundamentally that causes us all to dislike the system. And we don't like the providers because there's something wrong with people who are providing care in a system where everybody's not treated equally. It's sort of an insult to most of our sense of justice. And that really deteriorates our entire relationship between folks who are trying to get care and folks who are trying to give care. Can I talk about reform a minute, or should I hold?
Well, I know, actually I'm going to ask you to hold that
Okay.
till after Tom's.
Thanks.
Great, thanks, Jeff.
You're welcome.
Helen Taft is the Executive Director of Families First Health and Support Center in Portsmouth, and actually sees most of the uninsured.
And that is true. I do want to comment, though, we've been really blessed in the Seacoast to have people like Jay and Peter who have been really out there working outside the traditional system to really increase access to the most vulnerable people in the area. And I really have appreciated working with them and continuing to do so. So I'm here to represent community health centers. We are another very critical component of the safety net system. And although they always say you see one health center, you see one health center, there are some common characteristics about community health centers. My community health center is Families First Health and Support Center in Portsmouth, but there's Lamprey Healthcare, there's Goodwin has been mentioned. And so, in fact, there are over 1,100 community health centers in the United States, and they serve a total of 18 million people. And it's being said now, and Tom may address this, that the light is shining on community health centers now because over the years, community health centers have built a model that is really being looked at as a model whose components might be incorporated into healthcare reform. So I wanted to give you a little better idea of what is going on in community health centers. First of all, our services are comprehensive and they're prevention focused. We've heard some talk already about the importance of prevention. And many of us not only provide medical care, but we do put the mouth back in the body, and we do provide dental care. And some of us put the mind back in, and we integrate behavioral health care. So we truly are looking at a model that has a lot of different different components. And one of the most important ones, and I say this because I think in healthcare reform we have to think about it, are what we call enabling services. And those are the services that really help the people get to these programs, have the access, in fact. And that has to do with transportation. It has to do with translation. The Manchester Community Health Center, every other visit requires a translator. And you can imagine the cost involved with that and the time, but it's so key to the delivery of health care. You need care coordination. Many health centers are hiring what we call patient navigators because the systems are complex and they're very hard for particularly low-income and vulnerable populations to access. We also have been basically providing what now is the newest and latest jargon, the patient-centered medical home. And that is really about engaging with a patient in comprehensive care, providing full-service care, and giving them the management of any chronic conditions that they have, which we know then translates into cost savings. And there's also the community-centered medical home component to community health centers. As far as who we serve, we are very much focused on the poor, the uninsured, and the publicly insured, as you can see, if we can see that. The first bar is the uninsured, which comes in around 40% nationally. For our health center, it's about 50% in Portsmouth. Medicaid about 35%, and then 70% are below 100% of poverty, and then 91% live below 200% of poverty. So health centers are truly serving the most low-income and vulnerable populations. We're also serving the homeless. Nationally, about 5% of health center patients are homeless, and our program in Portsmouth, because we have a health care for the homeless program that's van-based and comes out actually down to Hampton, we're about 25% homeless. So it clearly is more targeted. And you'll see the different types of illnesses that are really much more chronic and more acute, actually, in health centers. I will say that the mental disorders is really much higher than 9%, but that's how it comes out, because there are so many of our patients who are really living with a lot of behavioral health issues, a lot of times due to their lives that they're living with. So what do we do about the uninsured in terms of trying to handle the costs in our health center? I mean, one of the big issues that we do have is access to other services. We have an internal medicine physician named Bob Milstein who actually used to practice, I think, down here. And he's very part-time for us. And he told me just the other day that having come from private practice and serving all these uninsured now in our practice, it has been a huge shift for him. Mainly because he's never sure that they're going to get to the services that he is hoping they get to, or he's prescribing that they get to, specialty care, prescription drugs, lab work, any testing, and he feels very anxious about that. It's just, how does that happen? So the health center really has to have an infrastructure in order to make that happen, and we do have that. We have a lot of staff who work on that. But you can see that the uninsured are only paying about 12% of the cost. And patient fees for us represent about 40% of our patient revenue. Privately insured are about 8 to 10%. There's no cost shifting that's really going on in our center. So needless to say, we are very dependent upon a lot of different subsidies and other funding sources, which includes grants and state contracts, a federal contract, and a lot of other just fundraising events that we have to accomplish in order to really meet the demand for services, which really is increasing, as you can imagine, with this economy. We're seeing double the number of applicants each month, and we're barely able to keep up with that. We're also seeing, because of the economy, reduction in other forms of funding, so we're having to deal with that. As was mentioned, recruitment of primary care is very, very difficult. A lot of shortage, as well as very competitive. And by having these new patients who are coming in, some delaying care, late to care, we're dealing with many more critical kinds of healthcare issues, and really impacting our providers and how they can manage that. So therefore, we're looking at some healthcare reform components that we'll be talking about, I'm sure, in discussion, and I won't read them all to you, but it really has to do with recognizing the critical role of the safety net and maintaining the ability to make sure that all low-income and vulnerable people can access affordable and accessible health care that is comprehensive, that focuses on prevention, and really does align payment and quality as well as accountability for costs. So I'll stop there since I'm probably out of time.